Hi, I'm Justine,
And I'm Sarah Levon.
and we are so glad you're here.
We believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every single person and patient you touch.
We want to inspire you with resources, education, and stories to support you to live your absolute best life, both in and outside of work.
But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together.
By nurses, for nurses, this is Happy Hour with Bundle Birth Nurses.
I don't want to say that I like emergencies, but I kind of like an emergency that goes well. I don't know about you.
I do not like emergencies. We differ in this.
Mind you, I can say that now because I'm not fully responsible for the emergencies anymore.
Right.
And the other side of this is that even if I am a part of one, I haven't been a part of one with my clients for a long time. And so I'm speaking more from my history. But I think that there is a lot of fear, especially if you're a newer nurse or even an experienced nurse. I know one of my good nursing friends, she's like, I haven't really had a crash in 5.5 years. And I'm like, well, that's great for you, but it's gonna happen. These emergencies, they do happen. If you're working in the hospital system, you will see hemorrhages and prolapsed cords and seizures and all sorts of crazy things. And so I think one, it's really intimidating. And two, what we want to talk about today is what our favorite emergencies are and why, and hopefully help shed some light and perspective on some of the scary stuff. This is a part of not this particular episode, but we do have an entire Some Scary Stuff module as a part of our Bundle Birth Nurses mentorship program. So if you haven't seen, we have a mentorship program. It is for new and experienced nurses, for you to continue to build on your career. And so we talk through a bunch of emergencies in there and sort of just bring and shed light and make them so much more simple, step by step, understand what's going on, understand your role, and then get to the other side. The goal is obviously healthy birth outcomes. And so while they are scary, I would say that I want to say the majority of the time we get to the other side and mom and baby are good. I'm going to say that loosely because, as we know, in the United States, our stats aren't very good. And so this obviously is multifactorial, but the goal is when we have an emergency, we want to give our best to our patients. We want to be ready for them. We want to know what to expect. We want to know what our role is and get out the other side with the best outcomes possible. That being said, we are both going to share our favorite OB emergency. I definitely have one that, of all the emergencies, is definitely my favorite. And so does Justine. So I guess I'll start with my favorite emergency. Again, loosely favorite. I'm laughing at myself because not my favorite, but my favorite. And my favorite emergency is a prolapse cord. And that is because, to me, prolapse cord is so incredibly self-explanatory and so not subjective. It is, if you have a prolapse cord, there's no is the heart rate normal? Are they tachy because they're bleeding or because they're stressed? A lot of our other obstetrics, I'm going to say emergencies, but also just the land of obstetrics is very flex and flow. That's why I say that all the time, that you're assessing and you're bringing it up the chain and going I'm seeing this change. What do we think? And a lot of times it's well, let's order a lab. Let's order this test. Let's keep monitoring. Let's give this medication. And you're sort of on edge the whole time thinking is things going to change, or is this really a problem, or is it going to turn into nothing? And a lot of times it turns into nothing. Hopefully you're seeing those minor changes, but a prolapse cord to me is so black and white. What happens? Water breaks or provider AROMs. If provider AROMs, then they're likely the one in there. Although I've seen actually they've been ruptured. Maybe it was a high leak and then something happens. You have a decel. One of our interventions when you have a prolonged decel is to assure that the cord isn't there. You check, there's an umbilical cord. If your hand is the one to check, you are going nowhere. You are climbing up on that bed and snuggling in with the patient and talking them through everything and getting that cord or the pressure on the cord relieved from the head.
Which is your favorite part, right?
For sure. And I think I've heard so many people be I'm so scared to be that person. But honestly, if you're in that role, all you do is call for help and you are stuck there. There's no running around like chaos. You're just able to coach the patient through. Look at me, take some deep breaths. This is what's happening. You turn into the education role and then you sweat bullets because it's hot and you're ending up like under the drape and soaked in fluids and stuff potentially until they get the head out. And so that piece for me to find the cord is like my favorite emergency because one, you know exactly what to do and we can talk through exactly what to do in a prolapse cord. I was very scared until I had a couple and then it was like, oh well, there's your steps. So what are the steps for a prolapse cord? You have a decel, you try turning them, you're saying no, nothing's fixing this decel. Somebody checks, let's say it's you feel a cord and a head. So when you're in there next time doing your vaginal exams and feeling those heads of the baby, feel what it feels like for there to be nothing. When there's a cord there, it will feel smushy. There will be an extra little something. I've had a prolapse cord where it was like out of the vagina, like you could see the cord out of the vagina, or I've felt it where I'm like, I think there's a little bubble by the head and I'm pretty sure that's a cord. And sure enough, one of the things from my first couple of prolapse cords that was surprising to me was you can likely feel a pulse. So even if the monitors don't work, you can look at your watch or look at the clock and sort of feel that pulse if it's touching you in any way, and a lot of times it is. It's either like pressed up against your finger, you don't want to press on it, but you can feel a pulse a lot of times. And so that's something you can be doing as you're assessing in there. So you press and push up of the head. Again, you have the beautiful opportunity to not leave this patient hanging. There is chaos ensuing around. Obviously, if the prolapse cord is there, you want to call for help and get everybody in and just say it's a prolapse cord. Start unplugging things with your other hand if you can reach, and then give the patient a heads up. My quick heads up is the cord has now fallen between the head and the cervix. It's being compressed. This is an emergency C-section scenario. 1 million people are going to come in here and we are going to get your baby out as soon as possible by cesarean, and obviously if there's a doctor there, they really should be consenting on all of that. But if like a lot of times what ends up happening is there's just everybody talking around the patient and the patient gets totally forgotten. And so this is an emergency scenario. We're going to take the best care of you and your baby that we know how, and we're never saying like your baby's going to be fine. I always say like you're in the best hands. That's usually how I go about that. So then you're pushing up and trying to create space between the cord and the head as you crawl on the bed and literally go running down the hallway for an emergency C-section.
You go riding.
You go riding, yes. And your hand never comes out. Never. The whole time. This is a non-negotiable. I was actually a part of a cord prolapse where I was not the one checking. I was running in to help, and it was actually an upper management person, told the person with their hand inside to take their hand out. And I remember looking at this manager and being like, what? And the nurse looked at me and I was like, I don't know. And sure enough, she took her hand out and the doctor comes in and is screaming like, why is no one's hand in there? And I happened to have a glove on and I was like, okay. And I like put my hand in, was like, well, now I'm under here again. But then they're literally draping over you and you're waiting until the provider literally grabs and you feel their fingers pulling the baby out. Or they tell you that you can, move your hand. It's sweaty. It's painful on your muscles a little bit, and you're probably contorting your body as they move over to the bed. You're like following them. I remember like leaning on and like being like my belly laying on their legs as they either get general anesthesia or something else. And then that's it. It's an emergency C-section. That's my favorite. What's yours?
My favorite is full-blown cardiac arrest.
What?
No, I'm just kidding. I'm not a psychopath.
I was like, whoa.
What is the surprise factor?
I mean, you did it.
No, I was thinking here about it. We were thinking crash sections earlier when we were kind of brainstorming this, that would be my favorite in the sense. I'm like, it's just so like, get them back there. But I think now abruptions.
Really?
Yeah. And I think
like a full-blown abruption or like
yeah, like whatever, any of them. I mean, not like when we lose one of them, but obviously, but I think with an abruption, you're like, okay, that's more bleeding than normal. Okay, look at the contraction pattern. We've had a lot recently, and I think if I was going to choose an emergency right now that I'm like feel comfortable with, I'm going to choose abruption because shoulders hate them. Hemorrhage is
goes hand in hand with an eruption.
Yeah, and hemorrhage is good, not good. This feels so weird to say, right? Hemorrhage is very systematic, but hemorrhages for me, this sounds so crazy, and maybe we'll edit this part out, but I'm like, hemorrhages are like old. Like, I'm tired of them. Like, I'm like burnt out of hemorrhages.
Old news.
Because I think they're just happening all the time.
Hmm.
And seizures are scary. I'm not gonna lie.
I don't like
Seizures scare
seizures.
me. We don't deal with them enough, right? Like they're so rare that seizures are uncomfy. Whereas like, my husband would be like, seizures are fine, whatever. Like, why do you care? Like, give him Ativan. I'm like, seizures are uncomfy. Prolapsed cord is not common, but you're absolutely right in knowing like there's like one thing to do. Elevate the head and go to the C-section, and you know what the cause is.
Yep.
So it is
so black and white.
So black and white. And so I think on all the theme of that, so I guess like just a crash C-section. And I think I like the adrenaline is at 3 a.m. is like so thrilling, right? And
your shift is over in no time.
And then the teamwork of it, and just being able to reassure the family and just grabbing everything. But I think with that, if a crash C-section freaks you out, some things to note. Your cords, right? Sarah is going to tell you all about your cords. And it's so true. Like if you're someone like me, Z-type, as we talked about in previous episodes, just look at your cords, look at the back of the bed. How is that all tangled up with the IV cords and the power cords? And because you're pulling and running, right?
Can I just give a tip on cords here? Because yes, this is something that like has always been not a pet peeve, but like I'd walk in and if I see the cords are a mess, like I can't hardly get report. And I try, but I'm like, I have to fix that. The
She's like that in the office now too.
I am, yes, with like anything we do with cords, and we do a lot of cordy things. And so to think about, like, I need to be able in an emergency, this is a part of your emergency checks. We talk about this in Scary Stuff in mentorship. You need to be able to unplug and go. How many times have you been a part of a crash where everyone's like, hold on, or like the reason why you've broken the remotes, you've pulled the IV out, you've broken an IV. I've seen IV lines snap and now like blood's pouring out, like out disaster, right?
Epidural line snap.
Epidural line snap. Now you don't have epidural access, like the whole thing. And so when you walk in, once you get your report and you calm yourself down and do lots of grounding like me in order to handle it, go untangle your cords and think, could I unplug and go? The biggest one that I see is the epidural bolus little remote thing that's tied around or the call light that's tied like in a knot or a half knot around the side railing.
Yep. So
that,
true.
In an emergency slows you down. And so when you're prepping for an emergency, we always need to be ready for crash C-sections. They can happen in like 1 second. And so be able to unplug and go.
Yep.
You're welcome.
Love that. You're welcome. Knowing where your splash kit is in the OR. So like, what do you do if they're not going to fully prep the belly? If you're going to throw iodine, where is that at? And what do you need to do to throw that on? And verifying if we're doing that. Like, are we splashing? Do we have a second? What are you going to do? And then calling out what you're doing is very helpful. Like in the feedback loop, right? So it's like, she needs a Foley. Okay, I'm getting a Foley. Justine's getting a Foley. Justine's going to put the Foley in,
like CPR class that feels always like the weirdest modules to do in CPR
so true.
class.
But that feedback communication. Closed loop communication is great in an emergency. Yeah. And obviously they know what they're doing when they're talking about that. But I think being in the OR in general is so nice because we talk about this all the time, especially in some scary stuff. The anesthesia team is our favorite team. They're the best people to have. And so utilizing them for blood, for meds, for intubation, obviously, are just there. What would we do without them? I don't know.
So let's talk through the steps of a crash. I remember when I was new, this was like my biggest fear on the planet. I had 3 crashes on orientation. That's what I mean. Like, talk about exposure, right? But until you have them, they're really scary. Well, they're always kind of scary, but eventually, to me, it's like, well, here we go. And so as long as you know your steps in your head, that'll help you feel more comfortable when a crash happens.
And now, and some hospitals have different verbiage, right? It's like some have to be less than 10 minutes, some less than 30
for a while
for it to get back there. So I think that, and so I am in the process of my own place of like incision to decision has to be less than 30, but I'm like, I thought it would be less than 10.
No.
But some hospitals cannot be less than 10, right? Because they don't have anyone there. because I have to call them in from home, like my last hospital.
Okay, so we're going
Hashtag,
to initiate a conversation on Instagram about this.
yeah.
Because you can have, if you have a terminal Brady, right, that like a D cell that goes, say, 60 and it's down, you can have brain dead baby in 12 minutes.
Mm-hmm.
So incision to decision to me is 6 is what I've heard. After 2 minutes, you need the people in the room and you need to move to the OR. So we will pause and find that out. I am
Yeah, because
almost positive on that one because you cannot wait 30 minutes. I mean, and mind you, if you're at a rural hospital where you're waiting for a physician to come in-house, you don't have in-house anesthesia. Obviously, we are speaking from our perspectives where we've always had resources like that. And so, of course, it's going to be different. So we will be talking about that on Instagram to see what your perspective is. But in general, we need to understand that obviously the quicker the better the teamwork. I know for me, I had a wow, this is a wild one. She had a ruptured Vilamentous cord. We had no idea what was happening, but all of a sudden profuse bleeding. My instinct was off about it, and this was probably one of the craziest cases I've ever had. Actually, she happened to be a VBAC, which was very helpful in her case because I was like, I don't know, did she rupture her uterus? I don't know, but for sure. And so thank God she was a VBAC, but she actually, like she said, I just changed her pad or whatever. And then she was like, I'm wet again. So I was like, oh, well, she had a little gush of fluid already ruptured. And I looked in her pad and it was bright red saturated and I had just changed her pad. And so my instinct, I just started unplugging. I turned off her pit and just started like getting her moving. And then the decel happened. And of course, like my team was like, they saw me call for help because I pressed the staff assist button. And they're like, wait, the baby's up. Something must be really bad because Sarah doesn't ask for help. And sure enough, they came in the room and I was already starting to wheel the bed by myself. And I was like, there's bleeding. We got to go. And sure enough, we got to the OR and our teamwork was so fast. Our nursing hands were off in 4 minutes from beginning of decel. And we were like, cut her. The poor doctor comes in and is like, what is happening? Who is this? Why are we, and both me and the charge were like, just go. Something's really bad. She was gushing blood. And sure enough, it was a ruptured Vilamentous cord. If you don't know what that is, you can look it up. Basically, the cord inserts into the placenta incorrectly and the vessels traverse the membrane. And so this is totally a tangent while you look up this, but that's fine. And so they traverse the membrane. And so when the membrane ruptures, it can rupture the vessel. And so baby basically bleeds out. And like the mortality on this one for a baby is really high. In this case, luckily, the baby survived. I actually got to see her for her second or third because she was a VBAC. And so anyway, we rushed her to the back and the teamwork on that one was the only reason why this baby survived. The NICU team was like, there was very little blood volume left, but there was. And so, when we talk about crashes and like sort of that like incision to decision time, there's an element of instinct. There's an element of like nursing assessment where I was like, this bleeding is way too much because I had been assessing her pad, because I had sort of like been in the bedside for so long. This was abnormal, coupled with the decel, coupled with the VBAC situation. Luckily, like it just, like I said, it was in her favor because she, I was like, she had to have ruptured her uterus. And sure enough, we pulled open the placenta and it was like this. We all looked at each other like, oh my gosh, this could have been so bad. And luckily, it was not. I mean, obviously, baby went to NICU and needed transfusions and stuff, but baby is totally fine.
Well, thank you for that. That was helpful. But it sounds like from what I'm looking up is that there is no gold standard and many happen in more than 30 minutes, even incision to decision because of the resources, right? And we talk about how we are very lucky, especially me now, is that I work at a hospital that I can do it in less than 10, but I worked at the place with 30 minutes, 45 minutes waiting, right? Lidocating a belly because there's no anesthesia, operating with no anesthesia on a pregnant patient. Like it's
wow.
Insane.
So if you're a pregnant person listening to this, that might be a consideration on the hospital that you choose.
Yep.
That would be for me. I'd want to know that, like,
you have anesthesia in-house? Do
right.
you have an OB in-house all the time? They call them either like hospitalists or laborists.
Mm-hmm.
So
steps for a crash. Now that we've talked Vilamentous cord insertion rupture, which was not the intent, and cord prolapse and abruptions, all leading to an emergency C-section.
You're at the bedside. You need to call help.
Mm-hmm.
we're crashing. You need to, the anesthesia needs to know. Your
Who's
NICU,
making the call on the crash?
the doctor is the correct answer. But like we just said, sometimes the nurses are like, we're going. So,
Mm-hmm.
but you need the final call of the doctor
Mm-hmm.
is
Well,
making.
and if you don't have a doctor there, just get to the OR. The
Mm-hmm,
goal is move to the OR, and then you're always going to reassess tones on
mm-hmm.
the baby. And maybe it's up, how many times have we moved to the back? And then you wait 20, 30 minutes in the back, and then you're like, all right, let's go back to our labor room. And they go on to have a vaginal birth. That happens all the time. So,
Yep.
But in general, get them to the OR. You can't do anything other than a postmortem in the room. And if they're alive and well, you got to get to the back.
Yep. So consent wise, you're getting, usually it's a verbal consent. Sometimes you can have them scribble on that line. You're unplugging and rolling.
Mm-hmm.
You are either putting a Foley in the back or the Foley is already in. You're not wasting your time in the room to put the Foley in. You
Or I've
are,
been in cases where they've said skip the Foley
yeah, I won last night.
and
We
put it
skipped the
in.
Foley.
Yeah. And then put it in
Yeah.
later.
Yeah. So you're going to get to the back. You're going to help them get onto the bed. They either have movement or not. They're going to go to sleep or not, right? If they have an epidural, they're not going to go to sleep. So you're going to know ahead of time if the family member can come in. They're going to get on the bed and you're going to take the bed out of the room, the labor bed out of the room and make room into there. They're going to lay down. You're not going to sit for a spinal in most cases for this. And you're going to, right?
Mm-hmm.
You're going to, someone's exposing her belly. Someone is lifting her legs to put a Foley in. At the same time, anesthesia is getting ready to intubate her or convert her epidural to a spinal.
Grounding pad.
Grounding
STDs,
pad, or
a
if
lot
you
of
have-
times you're skipping
You're skipping, yeah.
and put later.
You have NICU team needs to know, or the pediatric team needs to know. Whoever's going to catch that baby needs to be in there. RT, if they're going to be in there, you need to call your people. We have been on the way to a crash before and they're like, where's anesthesia? And I realized I didn't call them and they were in bed sleeping at their house.
Whew.
So that was
Bummer.
a gut-wrenching moment. So making sure you know who to call and that someone is calling, right? And this is that closed loop communication.
That typically is your charge nurse.
Mm-hmm.
But so if you're primary on that and this patient's going to the back, you're looking at your charge and saying, call all the people.
Yep.
Or what I would do, we had a lot of buttons at both of my facilities. And the moment you get in the OR, whoever is first in the OR is pressing the PEDS code. So the button to call the NICU people, or calling. In one case, we had a phone, and being like, they can be there getting set up because likely they're going to be like running a code on the baby. So the earlier they can get there, the better, but you're calling that emergency button, even if you're not even in the OR yet. Doesn't matter. If you're in there, somebody also needs to open a table. If there isn't a table open for the C-section.
In there open or someone. And you need to know if you're counting. So you can announce, are we counting or not? And the OB can decide that. If it's a not counting and they're literally splashing iodine in the belly and cutting, that means that afterwards it's going to take a little longer. You need x-ray to come in to confirm there's nothing left in the abdominal cavity because you didn't count beforehand.
Mm-hmm.
So there are a lot of things that are just like, we'll figure it out after. We'll slow down after the baby comes, right? That was said recently, like we will slow down after the baby's here. And so it's rush, 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 rush while keeping the patient safe, while giving a proper report. Like being primary, you need to know they know why this is happening. They need to know, or last night, even the Foley wasn't placed. And so right before I was like, do we know Foley wasn't placed? Foley wasn't placed. And we kept repeating that until the OB was like, Foley wasn't placed, because they need to know, they're looking out to like be more careful to not nick that bladder. Right. So making sure they hear you announce these things.
Mm-hmm.
But I will say it's usually chaos, but it's like orchestrated chaos.
Yeah. I would say organized chaos.
Organized chaos. We had one that the secretary later told me that postpartum nurses were watching us run down the hallway, take the patient, run back. And they were like, how long will that take? How long will the baby went out? They move so fast. How do they know what to do? And I was like, oh, that's fun that they like hadn't seen that before. Right. But it's, I asked my secretary, I was like, is it like a movie watching us all like bolt out of the station down to the room? She's like, oh yeah, she's like, it's crazy. But, it's a lot of teamwork. And so for those units with 1 to 2 nurses, just know that we are with you. And
I think what I would do if I was a nurse on 1 to 2, I would have my manager or educator. I would assume maybe you don't have an educator if you're that small of a unit, but have somebody talk you through what are the expectations in an emergency. If we only have 2 people, anesthesia's in bed, OB's at home, like,
anesthesia's at home too.
Yeah, that's what I mean. Anesthesia's in bed at home. Yeah. And so, what are the time frames that you're looking at? At what point do we call you?
Well, and so, and a
What
little,
are our
and
resources?
right, exactly. No, it's so true. How far away are you? Well, we learned it when we filmed some scary stuff, right? About retrofilling the bladder in a prolapsed cord so that the bladder moves the head up instead of the person's hand,
Oh yeah,
so
I
they
forgot
can,
about that.
right? So there's things when you work in a rural hospital like that, there are things that you can learn and do, and hopefully you have in place. You're
Mm-hmm.
using the ER doctor, right? And so are you doing drills? If you were really worried about that, like, can you do drills with the ER and have them come and talk them through? They can do a perimortem C-section. They did their rotation. ER physicians have to do 10 to 20 deliveries when they're in residency. Mind you, they don't want to do that, right? But at least they've
No.
seen some birth, so they can. And you've seen birth, right? So you can help them walk through the tech. If you have techs on your unit, they've seen birth.
Yeah.
They've done cesareans a million times. And so they can help walk them through. They're not like totally alone, but just like think about your unit and where everything is. And there's even nurses that go to the main OR. Someone messaged me the other day and was like, we can't even get our patient to the OR in 30 minutes because how far away it is.
Or like on another floor. I heard that
Yeah.
recently where it was like, yeah, our NICU's on the second, like a floor up. We have to go in the emergency elevator. I was like, in the elevator?
Right.
No, I've been very
So,
stressed. So what I'm hearing with the crash and things to keep in mind is that you got to clean them. So know where your splash and crash kit is. Know where that is in the OR. You might be that person. And so there's different types of kits. Some people are like, they dump it on the belly. Some have sponges where it's 1, 2, 3 across the belly. And are you clipping or not? Probably not in that
probably
case.
not.
But sometimes you might, if you have enough hands, somebody might be like, I'm going to clip them. And it's a zoo, zoo, and you're done.
And you might have enough hands to count too, right? Like
Right.
while they're
Someone could be
intubated, you can do a
counting
quick
while they're
count.
doing that. Yes. And if
Yeah.
you can get this stuff in, get it in because it's
Yeah.
technically safer and it leaves for
Yep.
less to wait for later. But you need grounding pad, leg strap. You're not tilting them to the side and they're falling off, please. You know, throw the drape on, and with a splash, you're not waiting the time to let it dry. So the drape goes on, it goes up, anesthesia is a go, and they cut to baby. And once baby's out, that's when you fix everything.
Yep.
So you need your people in the room. You need your table available. You need as many hands on deck without them getting in the way. If you're not doing anything productive, step off to the side and stay out of the way. And again, if there's something going on and they don't need help, go watch these cases. Even through the window, watch these cases. On downtime, go to your ORs and know where everything is. They're going to be asking for a ton of sutures, likely because they're not on the table yet. And a lot more supplies. And so you're going to need to be able to pitter patter around that OR, even in the supply rooms to get the things that you need because everyone's scrambling. But again, once it's called, you're in the back, wham, bam, and our nursing interventions are what I stated. You're hands off the moment that drape's on. And, the other pieces we didn't talk about was documentation.
Yeah.
And this is where like marking the strip when things happen, and then you can go back and like timeline it out later. You can see when the cords were unplugged. You can see when the heart rate was reassessed in the OR, and you're using that as your timeline. And then once baby's out, to kind of piece together what goes on. Is it going to be exact? No,
No one
it's not
expects
going
it
to
to
be.
be. They'd rather you save the patient than
Exactly.
chart live.
Yep, exactly. But once baby's out, or if you're extra hands, look at the clock and make notes. The best case, I remember one time I had an orientee and she was precepting, but it was like she wasn't doing much yet. She was just observing, and we had a crash, and all I said was, write down the times of things that happened. And sure enough, she came to me with my little piece of paper, and I was like, oh my gosh, this is brilliant, And after the chaos had ensued, it was like, oh, well, here we go. That's
what
so
I'm saying.
helpful.
A record keeper. These
Yep.
CPR people know what they're talking about. Closed loop
They do.
communication record. And you could assign that to a nurse too. Like,
Totally.
hey, take times.
Yep.
We
If you
forget
see
this.
someone doing nothing,
Yeah.
order people around. I've said in lots of other episodes and other things that like I became a dictator in emergencies. You do this, grab me this, I need this, like this, but also like you need someone guiding the ship. It's for any kind of project or emergency or life. Like someone has, if you're doing like I think about Zoom breakout rooms, like everyone's like looking at each other awkwardly, like someone just jump in, And if you're primary, that is technically your job. Now, if you see the primary who's not doing that or they're deer in the headlights, jump in and help them. We all respond differently to adrenaline. And so that's also where, like, if you're finding yourself being stuck or overwhelmed or like, I don't know what to do, make sure you've called your people, help with what everybody else is doing. And then honestly, I'd say take a big deep breath, and then it's like, go. You know, if you need that one moment for your body to just like snap out of it, take the moment to snap out of it so that you snap out of it rather than just stand there in deer in headlights.
Yeah.
You know?
And if emergencies still, like, you're listening to this and you're like, I'll never be there, I'll never be okay with any type of emergency, there's resources out there for you. We strongly believe in reading about it, watching classes. That's why we made some scary stuff in mentorship, just knowing the theory of it. Cause yeah, there's some things you might not have seen yet. And so that the fear of the unknown, right?
Yeah, just know your steps in your head. I remember the first time I
Yeah.
resuscitated a newborn, and I was so scared of that. And then because I knew the steps in my head, it was like, well, bag him. And then somebody else came, they took over bagging, and now I'm going to check a pulse and do chest compressions. And then like everything else, like, oh, we're going to suction and we're going to add the monitor and whatever. Call your NICU team if you have one, or you're going to have other hands there to like know the basics. And then it sort of starts to become a lot more common sense. But it's like, you kind of got to get past that deer in the headlights. And if you know your steps and you're like, that is as much as you can do. And then it's sort of that, just depending on muscle memory, knowing where things are, the more prepared, rather than like, well, I'll just see how it goes. Like, no, you can still take some things into your control. So you are a little bit more ready. And then learn to work with your team. Talk to the other nurses. What crashes have you had? What did you do? What did you learn from them? What would you have done differently? What was crazy about it? What worked really well? You know, like having those conversations in your moments at the nurses station, they do actually help to prep you for these emergencies.
Totally.
That's enough.
Yeah. What do we do for the ending? What little statement?
I feel like that's enough.
No, I know. I know. The honorable, safe care. That's what I mean.
Safe and prepared care.
Okay. Thanks for spending your time with us during this episode of Happy Hour with Bundle Birth Nurses. If you like what you heard, it helps us if you subscribe, rate, or leave a raving review and share this episode with a friend. If you want more from us, head to bundlebirthnurses.com or follow us on Instagram. Now it's your turn to take what you learned today, apply it to your life, giving safe and prepared care to every single patient you care for. We'll see you next time.